All right, well, good morning, everybody. I want to welcome you all to another Grand Round session this morning. And we have a very special guest with us today. This is Dr. Erik Hansen. Dr. Hansen grew up here in Portland. He graduated with honors from Yale and then OHSU Medical School. And then he went to UC San Francisco to complete his radiation oncology residency, where he also served as chief resident. And since 2007, he's been with the Oregon Clinic Radiation Oncology Division. He mostly works at Providence St. Vincent, but he also covers his colleagues over here, and he does gamma knife treatments here. He's served as president of the Oregon Radiation Oncology Society. He's a member of the American Society of Radiation Oncology, and he was selected by President Clinton as a United States Presidential Scholar. He's senior editor of the Handbook of Evidence-Based Radiation Oncology, which has been translated into multiple languages and is used worldwide. And he's here to speak to us today about what we as primary care doctors need to know about radiation oncology. Dr. Hansen.
Hi. Let's see. I have to do the financial disclosure. I don't have any. I might be open to that, though, if you have a good offer. Today I want to open up the black box that's radiation oncology. I think probably most of you have never been to our department, or if you have, you've only passed through very briefly. And so there's a lot of mystery surrounding our department. And I hope to make everything a little bit more clear for you about what we do down there. Very briefly, I'll just cover some radiobiology. That is not the mainstay of what I'll be talking about. I'll kind of give an overview of the technologies we use, and then talk about indications and what are some of the emergencies and urgencies that we can help with. And I think a real important topic is the role of radiation in palliation, and also how do we guide prognosis for patients, and then what is it like for your patients as they pass through our department? What is their experiences? A little bit about side effects and what our typical day is just as a physician down there, and hopefully have some time for questions as well. So as you may know, there's about 1.5 million people who develop cancer each year in the US, not including skin. And about a third of those people pass away from it. Overall, it's the number 2 cause of death annually. And the lifetime probability of getting cancer is about 1 in 2 for men and 1 in 3 for women. When we talk about cancer treatments, we think of it as local treatment for the primary tumor, regional treatment for lymph nodes if they're involved, or systemic treatment if there's distant metastasis. And radiation actually has a role in all 3 of those scenarios. And overall, about 60% of patients who have cancer end up getting radiation as part of their treatment. So it's a very common thing you're going to see with your patients who get it, and hopefully this will be a helpful talk. Radiation was first discovered back in 1895, and this is the very first X-ray of Mrs. Rungeon's hand. And radiation was then used to treat cancers the following year. The people got pretty excited about it and used it for all sorts of different things. This is the first English literature textbook of radiology. Radiation oncology didn't become its own specialty until the 1970s. And this is a photo of 2 different people who had skin cancers cured with radium. And back then, that was a pretty miraculous response because they would have had disfiguring surgery back then or just really had palliation. And so that led to lots of enthusiasm in the early 1900s for the use of radium, cancer being cured. And they made radium chocolates, radium butter. I like the Radione one that says it gives you the strength of iron and the power of radium. And people got pretty creative, and I think of medicine. We try to help people's pain, minimize suffering, and of course, improving sexual function is also a very important part of what we do. And sure enough, they made suppositories for it and advertised back then. But then the pendulum for the enthusiasm of radiation started swinging back the opposite way in the 40s after the atomic bombs. And then long-term inappropriate use of radium, people started getting second cancers. And then in the 50s and 60s, the term radiophobia actually was coined. And it doesn't surprise me. This was the very first kind of modern form of radiation, an electron linear accelerator. And look at this guy's eyes. He's pretty scared of this massive machine pointing at him. And then in the 70s, you had gamma radiation being used, and people being afraid of mutations and so on. And so all that led to this, decades worth of fear of radiation, and it's appropriate, but swinging to avoid radiation at all costs. But what's the real reality of radiation in 2018? And I think what you could tell your patients here in the Pacific Northwest is that it's natural and it works organically. So it's still very safe and effective. These are two patients I treated. These could have been right out of the textbooks from 1901. It's the same thing. We have really miraculous responses for even huge cancers. I had to give a talk for kids one time, and I showed the bottom picture, and one of the kids called that the pizza tumor. It works well. So how does it work? So really what we use is photons. That's what we do. It's same rays from the sun. And X-rays are generated when we shoot electron beams at something, and gamma rays are given off from within a radioactive element, like radium. What happens is we can aim those, and then they interact with the water molecules in the cell nuclei, and those produce free radicals that then interact with the DNA molecule and cause indirect ionization and DNA damage. Another type of radiation uses particles as opposed to photons, and the most common would be electrons. Protons are another kind that's used and heavily marketed in radiation. We'll talk about that. And those directly ionize and cause damage to the DNA. So what happens, though, in our normal body, our normal cells have a tremendous ability to repair small amounts of radiation damage that happen in them. So we all walk out in the sun every day, and you go out there, and your skin heals it because it inherently has the ability to do that. But the hallmark of cancer cells is that they don't have the ability to repair themselves well, and that's why they become more and more mutated over time. And so when we use radiation to cause some minor DNA damage within the cancer cells, that adds up and adds up and adds up and destroys the cancer cells sort of selectively because they aren't able to repair that, whereas the normal cells can. Now, the effects of radiation really depend on a lot of different factors. It depends on each tissue. Every tissue in our body has a different sensitivity to radiation. It also depends if you're radiating a small pinpoint area or an entire organ or a large volume of one. The total dose of radiation matters, but also the dose per day. It also matters how quickly or slowly we're delivering that every day or all at once and with an implant or in other methods. It matters if patients are taking radiosensitizing drugs, which most commonly will be chemotherapy, but there are certain other drugs that can do that too. And then whether or not they have genetic conditions that predispose them to radiation sensitivity. Importantly, and a lot of patients will ask this, is, well, if I have to have a certain total dose, can I just get it all at once or twice or 3 times? And the answer is that the physical dose of radiation is not equivalent to what happens biologically to the body. Because the normal cells are able to repair those small doses, they can't repair a big, massive dose all at once. And so we do have to take advantage of that, and we call that fractionation. So for us, when we go through our training, it's 4 years. We have to pass 3 sets of boards. We do boards on radiobiology, very painful, boards on radiation physics, and then our clinical boards that are written and oral. And so we spent a lot of time learning all that, and there's a lot to it. So yeah, the example, the patients always want to know, well, why can't, you send someone for prostate cancer radiation or breast cancer radiation, and they're there for 3 weeks or 8 weeks, and why can't it be done faster? And this is an example. This is if you go out in the sun every day for 20 minutes a day, you're going to get a good tan, and that's it. You go the same number of minutes all at once, you're going to be burned pretty good. And the same thing happens internally, essentially. So going faster increases side effects in most situations. There's a lot more to it. This is the kind of standard book that's used by radiation docs all around the world. 600 pages worth of radiobiology if you want more. So how do we do radiation? There's a lot of different ways of doing it. And today, in 2018, basically it boils down into two categories. External beam radiation, where your patient's laying there and then we're shooting beams focused in on their cancer. Or we do an implant where we put needles into someone or a hollow tube in the cavity and then give off internal radiation temporarily or permanently. And so again, we use photons primarily. Electrons we'll use for skin cancers. And then when we talk about using external beam radiation, you'll hear different terms thrown about: 3D conformal radiation, intensity modulated radiation, or that's IMRT. There's a newer version called volumetric modulated arc radiotherapy, or VMAT. That's what we use. And then we talk about stereotactic body radiotherapy or stereotactic radiosurgery. That's basically very pinpoint radiation. And now also in the last 5 or 7 years, we've started using what's called image guidance. So when someone's laying there for treatment, immediately prior to treatment, the machine will rotate around them and basically give us a mini CAT scan of them internally. And so I can say, well, I originally mapped out the tumor here, and here it is today, and I can get it lined up pinpoint on the spot. So it's much more accurate. Today's radiation is not radiation from a decade ago. So this is a picture or a diagram of what a typical machine for almost all your patients that they would see. What happens, they come in, they lay down on this table or a couch, that can move, and then the gantry is where the radiation shoots from, and the imager is kind of on the side and can give us a picture, and all this can rotate in different dimensions. And so within the head of the machine, there's a electron gun. It shoots electron beams up here, and they hit a metal target made of tungsten, and that then converts to photons, and they shoot down this way. And here, there's something called multi-leaf collimators, and basically, and this is all under computer control, those can move in and out and constantly and shape the beam, basically. And so this is a video from the manufacturer of one of the machines we use, showing kind of what happens. And so if the patient's laying there, this can move side to side, and it can rotate, it goes up and down, and so on. And the machinery is very accurate to a millimeter. So it's very precise movements that we can achieve. Then the machine will go around, and they might have got an image before to make sure it's lined up on the spot. As it rotates around, this intensity of the radiation can change. It can be stronger in some areas, weaker in other areas. We can rotate in different beams, and then it can be shaped differently as it's moving around you. It is constantly changing. So in the old days, we would take an X-ray, and that's not that long ago. I did it in my residency in 2002, where you draw like on an X-ray, treat that lung tumor that I see. So this is way more sophisticated. About $3 million just for the machine. And it goes up to $7 million. And then the software to run it will cost about $500,000 without the annual, probably $100,000 in ongoing service and upgrades and so on. So it's pretty expensive. The old radiation looked like this. So this is a patient with a nasopharynx cancer. It's an axial CT scan. The nasopharynx cancer is right there, and you just shoot a beam from each side. Everything in the middle got the dose you needed to get to kill the tumor, but then everything else got that too, and patients would have permanent dry mouth and other problems. So IMRT was this, lots of little beams, and that's what I was showing there. The first version we sort of actually semi-manually did that. We'd pick 5 or 7 or 9 beam angles and do that, and now it's all automated in an ARC, and there's no human being who could do the calculations that the software can do for us. That's what this is. This is a man I treated with prostate cancer, for instance, and all these little green lines are the beamlets. As it rotates around, it creates a very homogeneous dose within the prostate here, protecting basically the bladder and the rectum back here. It's a little low dose here and here, and that's why side effects today are a little bit less than they used to be. In particular with image guidance, now that we can track the location of tumors within treatments or between treatments. Gamma knife, we have that here at Providence, Portland. That is a even more precise way of doing radiation. It has sub-millimeter accuracy. With this, we actually screw on a frame to the patient's skull, and that holds their head absolutely perfectly still. And then within the treatment machine, there's hundreds of little cobalt radiation sources that we can kind of open little windows briefly to shoot little parts of the tumor all at once, and can be extremely accurate for brain tumors. Next year, late next year, maybe into 2020, we'll be one of the first in the Northwest United States to get what's called an MRI LINAC, and basically that's the similar radiation machine what I showed the video of, but it has a built-in MRI. So when the patient's laying there, it will take either a live MRI where it's like a cine X-ray, and you can watch lung cancer moving within the chest and be sure it's lined up perfectly. And the advantage is MRI gives you better soft tissue anatomy. And then also with that, because it's so accurate, and each day, and for instance, in prostate cancer, the rectum's filled differently and the bladder's filled differently day to day. You actually can make a brand new plan right there while the patient's on the table. So we call that adaptive radiotherapy. So just even more precise in protecting other tissues. Brachytherapy is called internal radiation, and the original way of doing this is with a prostate implant. Basically, you would take little tiny radiation pellets the size of a grain of rice and put them up into the prostate. You could also do it for cancers all over. You've done it in the base of the tongue. But you put these little radiation seeds up into where you need it to go, and then when you remove the needle, you leave the seeds behind, and they'd give off internal radiation for a couple of months. A newer way of doing that, which we've transitioned to here in our program, is called high dose rate brachytherapy. This is called low dose because it's giving off low dose rate over a period of a couple months, and it stays within you. High dose rate implants are temporary implants, so you put in catheters basically, or a larger tube, for instance, if you're doing gynecologic implants, and then you attach those catheters to a robot here. Inside of that is a single, more powerful radiation seed, essentially. And then once you have it there, we'll have our scan, and we mapped out where we want to treat. And then same thing under computer control. The computer can help us figure out, all right, let's send from here a radiation seed up here. It'll stop here for 13.3 seconds, here for 12 seconds, here for 2 seconds, in this spot 27.23 seconds, and 8 seconds, and so on. In and out, and over about 10 minutes, you're done with your radiation. You remove the catheters, and then there's no radioactivity left within the patient, and it's much more accurate. And that's important because with the old-fashioned implants, when you put seeds in, you'd get some internal trauma and bleeding and swelling, and those seeds would move, as a prostate swells or other targets swell, then things move a little bit. You could have a perfect implant at the moment of the implant, but then over the next month or two, things kind of shift, and maybe you end up with not quite an optimal implant. This is optimal because the patient's anesthetized and paralyzed, and the radiation's done right then and there, and you get what you get. But with radiation, I've gone over, boy, things are moving fast. We're getting all these new technologies. Newer isn't better, and I think, that's true across medicine. And this was a really nice study where the Radiation Therapy Oncology Group, which is the national cooperative group for clinical trials, looked at all the randomized trials published over a decade or so. And they compared, did the newer innovations improve outcomes versus what was the standard of care at the time, and it was 50-50. So the point of the article is we still need to do randomized trials for all that, and that it isn't always better to do the new technologies. And sometimes being more precise isn't a good thing for cancer, because cancer isn't always so precise. It's not a perfect little marble with a smooth surface. It may be more like a tennis ball with a fuzzy surface, and the more fine you get on it, then you risk missing some of it. The poster child for that, for newer is not better, is proton radiation. And proton machines can cost upwards of $100 million to build. In fact, most proton machines in the country are actually owned by investment banking companies. or they're joint ventures with multiple hospital systems and investment bankers. And so they are beneficial for children with some rare tumors and very unusual skull tumors and spine tumors. There are not enough of those patients in the United States in a year to make back the money that is needed to invest in building those machines. And so they have to market it to the #1 cancer in men, prostate cancer. They market it to breast cancer, lung cancer. So just the most common cancers, even though there's actually no benefit for those. And then they market them like crazy and lots of ads and so on. So what do we treat with radiation? Well, basically all cancers head to toe. But we also do treat benign conditions, and I actually do a lot of that personally. Arteriovenous malformations is a common thing intracranially when it can't be embolized or can't be resected safely. Trigeminal neuralgia, actually, I'll treat pretty often when it's refractory to anti-seizure medications or pain medications. Sarcoidosis, I'll sometimes treat. Keloids, definitely for people who form keloids a lot. If you resect it and then you followed up with some radiation, then most of the time it won't recur. Graves, ophthalmopathy, gynecomastia we'll treat in men. It doesn't shrink the breast, but it kind of stops it from getting worse, and more it helps pain. Dupuytren's disease, man, that's really blown up, and it's the power of social media. Somehow there's all these Facebook groups on Dupuytren's, and somehow my name got on there, and it's like every other week I'm seeing a new patient with Dupuytren's to help. Basically, for radiation for Dupuytren's it's helpful once the nodules are forming, but once you get contractures, you have to have surgery first to release it. But if you do radiation while there's still just nodules before the contracture starts, 90% of the time it'll halt it. And then we'll treat it for heterotopic bone formation. We'll do that with orthopedists sometimes. So what are radiation urgencies and emergencies? I'll show you a couple of cases. This lady, she's 55, came to the ER after a fall with back pain and neck pain. She's got mediastinal and axillary adenopathy, as you can see, bone lesions at C6 and other bone lesions. And we were called about a C6 pathologic fracture, and can we get treatment started? There's another one, 79-year-old woman who had a history of stage 3 breast cancer. She presented with severe back pain. You can't miss that. And called about impending cord compression. And so the thing I like to just point out to everybody, and it's important for us to remember, because all I ever see is cancer. If you call me about any of your patients, pretty much I'm going to say, okay, well, what kind of cancer is this? But I have to remember, too, there's a differential. That first patient had sarcoid, and the second patient had osteomyelitis. So it's a good thing we didn't just jump straight into radiation treatment. So within radiation oncology, we always say, tumor is the rumor, tissue is the issue. No meat, no treat. So it is important to make sure that they really have cancer and before moving too quick. So with spinal cord compression, most commonly patients present with pain, half the time with a neurological deficit. MRIs are always better than CT if the patient can have that. And then you want some kind of pathology. Often they need to get started on steroids, in particular if they have a neurological deficit. When should a neurosurgeon weigh in? Pretty much it boils down to if there's instability of the spine, if there's bony retropulsion as opposed to just, say, a soft tissue mass, and then if it's a single site. So, let's say they have one vertebral body or 2 or 3 contiguous vertebral bodies, fine, but if they've multiple up and down the spine, most neurosurgeons aren't going to get involved. And the reason they should be involved in those situations is there was an important randomized trial that was done that looked at doing radiation alone versus surgery first, then radiation, and basically patients who were in those situations who had a limited single site, if you did decompressive surgery first and followed up with radiation, more of those patients maintained ambulation in the long term. But for us, when say, surgery is not indicated, it is important to get started sooner rather than later. And the reason is if a patient's ambulatory before, they're pretty likely going to remain ambulatory. But once they get paraparetic or paraplegic, the chance of getting better is not great. So you really want to get on top of it. I think in reality what happens, in my experience, is most of the time it's not so much delays on once they get to the hospital, it's more about delays getting to the hospital, just patients sort of ignoring things or delays for whatever reason getting to us. And then it works great for pain as well. So about, I'd say, typically 70 to 80% of patients will have pain relief. It's not immediate. It takes the fastest I usually will see you 2 or 3 days, but more commonly it'll be a week or even 2 weeks later before you get pain relief. SVC syndrome, as you know, most patients, facial edema or distended neck and chest veins, that's the most common thing. CT chest with contrast, we need PATH. And then most commonly it's going to be lung cancer or lymphoma. Steroids, consider. Radiation works great. About 70, 80% of the time it will work, and especially if it's lymphoma or small cell lung cancer, it'll respond very fast. Chemotherapy is also really good for lymphomas and small cell, and we work closely with the oncologists on figuring out which is the best sequence to do. I think what's important, at least in my experience, at St. V's is a lot of times when patients have SVC syndrome, and they're pretty sick and in the ICU and so on, and oftentimes palliative care has been called, or hospice, and it's very important to let us weigh in if possible, just because I've actually seen patients who I knew would have got better, and then they died in a week or two because we weren't asked. And if we had gotten involved, we could have given those people a lot more time potentially with their families. So call us; it's worth it. This is an example of a big mass, tiny slit of a SVC. You do radiation within a couple weeks, and it's completely improved. Airway obstruction, same thing. Radiation opens airways 60, 70% of the time. And it takes a week or two. I saw this case at 7, 8 years ago, and a med student published it. Great response, and within 7 days, her tracheal lymphoma melted away, and she did really well. So malignant bleeding, radiation also used. About 80% of the time, the radiation will help, and it usually kind of cuts the bleeding down within a day or two, but not that same day. So if they're bleeding so profusely that they're needing transfusions and so on, it's better to get a surgeon involved at that point to try to cauterize or Moncell's or whatever to stop the bleeding first, and then follow it up with the radiation. Brain mets. So brain mets, multidisciplinary neurosurgery will be involved, oncology will be involved. When there's 1 or 2 or 3, nowadays, most of the time we do radiosurgery, which is gamma knife, as long as they're small. If they're a single metastasis or occasionally 2 or 3 with a real big one, neurosurgery will be involved. And historically, when there was 4 or more, everyone got whole brain radiation. That pendulum has really swung the opposite, and now many, many patients, even with 10 metastasis, will treat with gamma knife to spare cognition, and because people with stage 4 are just living so much longer as all our treatments are improving. This is a case of a physician I treated who presented in 2007, and she had expressive aphasia, and she had 7 brain mets, one of them pretty big in a bad location. She had bilateral lung nodules and adenopathy, and she had biopsy-proven lung adenocarcinoma. And so when I saw her, she had been just out of the ICU to the floor. Hospice had been involved, I'd been involved, and oncology involved. And she talked about all the options and so on, but elected to have treatment. Back then, when we talk about prognosis for someone with brain metastasis, they're not all the same. So depending on the stage of breast cancer and how it's spread and so on, or melanoma or non-small cell, each histology is very different, and within each histology, there's all sorts of grades of brain metastasis relative to the state of disease. And so in 2007, these were some curves that I had available to me to help kind of guide discussion about what prognosis might be. And this is where she would have fallen back then. And so back then, the average or median survival is 3 months then. That's, if she said, well, what's the median survival? 3 months. That changes over time. And so today, in 2017, we have the same conversation. The median survival is 14 months. With the same adenocarcinoma spread the way hers had, and so on. But she actually lived 7 years. And so she didn't live 3 months, she didn't live 14 months, she lived 7 years. So we aren't able to perfectly prognosticate exactly how things are going to go. She chose to have treatments and actually did great with all of them, and was able to see her son graduate and had a good time in life for that period, rather than transitioning straight to hospice. So the median survivals, I really discourage you from discussing median survivals with patients, because that isn't an accurate reflection of what may happen. Stephen Jay Gould, he's a paleontologist or anthropologist at Harvard, and he was diagnosed with abdominal mesothelioma at age 42, and the median survival for that was months. Terrible, and he wrote an essay called "The Median Isn't the Message." It's available online, and it's a really, really wonderful, wonderfully written message. And I actually would like you to just take a moment to read this, because I try to impart this to patients. So he lived 18 years, not months. And I have countless examples of that. And so this guy I treated in 2008. He had metastatic melanoma. Back then, only about 15% of patients with metastatic melanoma would live for 5 years. He said, that's fine, I've had a good life, and I don't want anything, but please take care of these couple spots that are bothering me. And I did that on 5 times over 3 years. And he did great. And actually, 10 years later now, in 2018, I just got his latest note on him. He is still completely cancer-free with no drug treatments whatsoever. And so what has sort of changed is that there's now, stage 4 is not stage 4 anymore. We have oligometastatic cancer, and that's where the cancer is very limited in its spread. And so when we combine that with new, better drug treatments from our awesome oncologists, plus radiation is just better able to target things and be more precise and have minimal toxicity, we can really have patients living a very, very long time. And actually just this year, even just last month, new randomized trials have come out showing in different situations for stage 4 breast, lung, prostate cancer, adding radiation to systemic therapy for stage 4 disease actually improves survival. And then you have what's called the abscopal effect. It turns out that for patients with stage 4 disease, sometimes if you radiate one spot, that exposes the immune system to the internal peptides of the cancer and so on, and basically the immune system says, oh, what's that? And recognizes it and then starts attacking it. And this is an example of a woman who had stage 4 breast cancer who, riddled with cancer. She had palliative radiation to 3 sites, and then 10 months later came back to the hospital having had no drug treatments at all because she had a fall, and gets a different PET scan to just figure out what's going on. Her cancer's gone. We don't have a magic crystal ball to know exactly what's going to happen with each person. And so when you discuss prognosis, and what I do is we have to, first thing is say, look, this is a best guess. That's all I can tell you. You have to be very honest and straightforward about that. But I think it's okay to show amazing scenarios. There's nothing wrong about giving hope to someone. But you also really want to give them what's the realistic picture of what's going to happen, and what's the worst case scenario too, and talking about both short and long-term big picture outcomes and how's it going to impact function besides just length of life. And then of course family, and their goals and how money, that matters too for a lot of people. So. We as radiation oncologists are here to help with that. So I always personally very much want to be involved in those discussions earlier rather than later. What is your patient's experience when they come down to our department? Well, first they'll meet with one of us, usually for about an hour or so, do an H&P, and usually we'll show them the pictures of their scans and so on and talk about the plan. We've usually coordinated that ahead of time with whoever else is involved. Assuming they're going to go forward with radiation, we do what's called a simulation or a planning session where we will get a CT scan, typically of the person in the treatment position, and we'll be mapping out the area of the body that we want to treat and decide how how best to position them for our machines, how to immobilize them to limit setup error. We usually will give them skin marks, which serve as a very initial form of alignment. And then we decide whether to give contrast and so on. And so the typical tattoos are these little tiny dots. These are I'm actually magnified these because you can't hardly see them. And then we'll use vacuum bags. That's the most common to kind of reproduce the person's position each day. With stereotactic body radiation, we use basically very fancy medical saran wrap that is suctioned down on the person to hold them still in the bag. And for head and neck cancers and some brain cancers, we'll use these thermoplastic masks. Basically, it's a flat sheet of plastic that you heat in a water bath and then stretch it across your head and put it on. You can see through it and breathe through it. I actually had one made for myself just to see what it's like, and it feels like a warm washcloth at first going on, but then it holds you pretty still, so I get it when patients who are claustrophobic are a little nervous about that. But I have so far yet to have a patient who can't wear that. Even if you give them Ativan, they'll be fine. We now also can use what's called a active breathing controller, which is the machine is directly tied in with the patient's respiratory pattern. So as they breathe, the beam will turn on or off depending on what phase of respiration they're in. So if the tumors, you're aiming in one particular place as the person breathes and their tumor's going up and down, beam on, beam off, beam on, beam off, and so on. This is the Gamma knife frame. We give 4 lidocaine injections to make it go numb first. That hurts, but then after that, you screw this frame on. It feels like a tight hat going on, and then you sort of get used to it. And the screws just go to the outer table of the skull, and that's what helps hold the head perfectly still for that, because it's the most accurate form of radiation we have. Once the setup is done, then behind the scenes, Gamma knife, you do it all then and there because you got the frame on. But for everybody else, then over a week or so, or depending on, sometimes just a day, we do planning. And what happens is then I will go and I'll sit at a computer with a physicist and a dosimetrist, and I'll draw out on the CAT scan in 3 dimensions where the target is that I want treated and where all the normal places I need protected. I'll tell them I want this dose here and that dose there, and so on. And then the dosimetrist and physicist will work on the computers behind the scenes, and I'll go back and forth checking with them, and they'll say, hey, that looks really good here, but I want it better there, and so on. And then before the patient, well, that's just drawing on the areas what we do. Oh, yeah, so what do we draw? I've had that question before. So when we aim at a tumor, what do we do? So first we draw what's called the GTV, or the gross tumor volume. That's just what you can see on exam or on imaging. We put a CTV around it, and that covers the microscopic extension, that tennis ball analogy I made. If there's a little fuzz on the outside of the tumor that's too small to see, but we know it's present. And then the tumor actually in many parts of the body will be moving like that. And so then we add on what's called ITV, or an internal target volume that covers a little room for motion. And then last, we'll add a tiny margin for setup error. Just because even though we put on all these things to immobilize, there's still internally a couple millimeters or more of setup error. So the patient comes back, and then we set them up on the machine and do a bunch of calculations and measurements and making sure everything is set up exactly the way they planned. And a Gamma knife is a single session treatment for brain tumors. That's done, the actual treatments, anywhere from a half hour to 3 hours. All the regular radiation treatments that we'll do are typically about 5 minutes, occasionally 20 minutes. And usually they're on a Monday through Friday basis, sometimes 2 or 3 days a week, depending. And then the duration could be anywhere from 1 week, 2 weeks, all the way up to 7 to 9 weeks. And we will, at the last day, usually order appropriate follow-up scans and so on, and give them instructions. So what about side effects? So side effects of radiation, each tissue has its own inherent sensitivity or not to radiation. So where we radiate and the volume of tissue we radiate is what's going to affect that. Basically, the side effects are due to the radiation exceeding the ability of those normal tissues to repair the damage that's happening to them. And so, importantly, the side effects typically are only going to occur where we radiate. So if I'm radiating a prostate cancer and someone develops lung issues, it's not prostate radiation. Patients don't understand that. They think, oh, yeah, I'm getting radiation, it's going to affect my hair and everything. But that's the fact. And so there's all sorts of different side effects that are each organ in the body. The skin, it's just going to most commonly be a red sunburn, and that'll get better with time. Skin in particular is pretty predictable as to how it will recover. And anytime there's a question about one of your patients, feel free to call, and I'll tell you, oh yeah, that'll get better in X days or whatever. Brain, you'll sometimes get peritumoral edema, and that'll cause headaches or seizure or so on. Sometimes you get inner ear effusion, and that'll cause earaches. Memory problems after radiation, that was more common with whole brain radiation. Nowadays, again, we're using gamma knife more and more for most or many brain metastases. Usually the risk is about 25 to 50% of patients who have whole brain radiation will develop short-term memory problems within a couple of months after radiation. But if you compare them to patients who you leave the tumor untreated, it's actually less because the tumor will do that anyway. Head and neck cancers, that's a tough area for patients because mucositis is just brutal, and it is not an easy course of radiation to get through, but we have a really awesome multidisciplinary team to get them through. The chronic dry mouth is an issue, and we have really excellent dental oncologists who we work with, Amber Waters, and other team members to help take care of them as well. And then new planning nowadays, we can do a lot better job sparing that. Lung pneumonitis, it can happen, but it's actually a small risk, 1 to 5%. It's not very common, but it does. And when it happens, it can be challenging. Usually prednisone will take care of it for the majority of patients. But it can take a while to get off of it. Breast, that's usually just skin irritation primarily. Sometimes you still have kind of shooting pains within the breast and that kind of persist long term, and part of that's related to the surgery, part of that's related to the radiation. GI, diarrhea, and urgency to go are common, and Imodium and Lomotil tend to work for most people. GI bleeding, not super common, but it maybe 5 to 10% of patients who get high dose radiation will get that. And, but now with modern planning, it's still, I think that's actually getting less and less over time. Urinary wise, yeah, prostate and gynecologic cancers, frequency and urgency, that's common. All the usual medications for those will help, Flomax and so on. I think with all these side effects, though, the key is that I expect to be involved and want to take care of those. But in reality, patients will leave the office and then they'll go call you, or they'll call their oncologist and say, I've got this problem, and then God bless you for taking care of that a lot, but you don't need to. Call me. I am happy to take care of it, and we should. And so I think communication is the key there, because having seen so many patients through it, we know what to expect and how to manage it. So the common questions I'm asked, will I be radioactive? The answer almost always is no. The exception is permanent prostate seed implants. Will I lose my hair? Usually no. Brain and head and neck, yes. And then I one time had a guy who was super hairy all the way around. He lost hair from prostate cancer radiation, but most people don't. Will I be tired? Yeah, you might. And it takes a little while to build up. I think that the main mechanism I see for tiredness related to radiation is that as the tumor cells are being destroyed, essentially the immune system is attacking them, and that just sucks a little bit of your energy away to do it. Most patients, it's a mild or a moderate fatigue. The really severe fatigue, that's usually when combined with chemo. And I'm not blaming chemo, it's both, but that's when I see it. Can radiation cause cancer? The answer is yes. But that risk is really, really low. It's about a 0.5% excess risk 15 years after the treatment. With fractionated regular radiation. With gamma knife, it's actually 500 thousandths of a percent risk. So it's super low, and you have to put that into perspective of, I got to cure the cancer that I'm facing right now. And then, is it safe? And the answer is absolutely, because especially here within our region-wide program, we have a very robust quality assurance program in which we have daily checks, weekly checks, monthly checks, annual calibrations. And we do that not just generally, but for each patient. So each patient, for instance, before they even show up, most of them we'll actually have a kind of a fake human being with a bunch of internal radiation monitors, and we'll run the radiation plan that we've designed for that person on that, and then we get the readout and we say, is what we planned actually being delivered in that body the way we expected it is. The other thing with that is we, at least, I'll mention this later, that we're one of not a lot of places that actually went through the process to be nationally accredited for our safety program. And most radiation oncology facilities don't do that, but we actually did because we do a good job at that. So what do we do all day? A pull, that's the typical thought, kicking back, playing Minecraft. That's not what I do all day. So yeah, I'm actually pretty busy most of the day. So seeing inpatients, outpatients, patients under treatment. I'm typically taking care of 25, 30 patients in a given day, checking on them, checking their daily x-rays. The planning actually is a big part of what I do, sitting down and drawing on the computer where tumors are, where normal tissues are, and working on that. Reviewing the plans and checking the physicist, and because ultimately I'm responsible for all that. And so I got to be checking what the physicists are doing, what the therapists are doing, setting up. We also have a peer review of each other's cases every single day in our departments here and at St. V's and at Clackamas. Before we map someone, we talk to one of our partners and like, here's this patient, this is what I'm planning, thoughts, and so we're really good about that. And then we also are all going to CME all the time because, especially in our field, it moves fast. And so, we're very fortunate to have a good group of docs who are staying up with all the latest information. And really, for me, though, it boils down to I can't take it back. If I treat someone, that's done. You can't take it back. So we're pretty type A for treatment. Hopefully not personality-wise for everything else, but at least for radiation, I am. And so I guess it doesn't matter where your patients go for radiation, and I think it can. I'll just speak to what we do, at least here at Providence, Portland, and at St. V's and at Clackamas. We do have all the latest technologies. As I mentioned, we'll also begin MRI Linac, which will be among the first in the whole United States. We have excellent on-site support services because what we do is more than what just the doctor can take care of it. Our nurses, our social workers are involved, speech and language, integrated medicine, genetics, all that. We're just a great team. Also, our group is blessed to have a lot of us. A group of 10 radiation oncologists is considered one of a really big group of radiation docs. Most places around the country, 1, 2, 3, 4 docs maybe. So it allows us to each subspecialize. And we're all published, and our outcomes, we've even published a big series showing our outcomes match even the very best academic centers. And we have a high volume program for radiosurgery and long experience with brachytherapy. We also are very involved in research. Christina Young, Mark Crittenden, and Steve Sung, MD, PhDs here, involved in the immunotherapy program. We're all involved in different clinical trials. I'm leading a nationwide clinical trial on speeding up post-mastectomy radiation for breast cancer. My book is used by everybody. And then we all are involved in different local and national organizations. And then I think importantly, as I mentioned, we have an accredited safety program. And we have full-time physicists. Not all radiation facilities actually have a full-time physicist. And and our peer review and so on. And actually, the other thing I'm actually proud of for us is just like the surgeons, we have a good M&M. Most radiation programs, when complications happen, it happens and kind of shoved under the rug. We're really frank and honest with each other about, anytime there's unusual complications in our M&M program about how can we improve things and so on. This is our team that I come over here to help cover, and I treat gamma knife here, and I do brachytherapy here. The main people here, Steve Bader, Marka Crittenden, Steve Sung, Matt, and Alice, and Christina. And then the other four of us, are Dave, Brian, Jeannie, and me, are mainly at St. P's. So we've gone through a lot of info. Questions? Yes. Yeah. So it kind of goes back to, there's what historically we would call radiosensitive tumors and radioresistant tumors. Sensitive ones would be lymphoma and small cell, and resistant ones would be renal cell and melanoma, for instance. And I think that it harkens basically to the genetic mutations that are present. And so within many lymphomas and in small cell, their predisposition genetically to apoptose with minimal further DNA damage is very high. And then renal cell and melanoma and so on, less so. So yeah, there's a lot of cellular biology on it. And I'm very much oversimplifying the biology involved. There's other stuff, telomeres and RNA and other repair mechanisms, and time matters also, how quickly you're doing the radiation and so on.
Well, that's great talk. Why do you choose brachytherapy versus external beam in prostate cancer?
Sure, that's a good question. So prostate in particular, those consults take a long time for me. That's one of the big things I do. And I sometimes spend 70, 90 minutes with people. There's a lot of balances for prostate in particular. If you're not going to go surgery or surveillance, totally appropriate options for many patients, and you know you're going to go radiation, choosing external beam and an implant is affected by a lot of different things. Sometimes an implant just isn't possible because for the prostate's too big, or you've had a TURP before, or the pre-existing urinary problems are so bad that then poking in a bunch of needles causing internal swelling is just going to squeeze down on the urethra further, making things worse. So sometimes the decision's sort of easy in that regard, but if those things aren't an issue, patients will be it really boils down to, they'll say, I would rather get it done quickly, just 1 or 2 visits to have an implant, and others will say, well, the reason I'm choosing radiation in the first place is because it's non-invasive. I don't want to have anesthesia, and I don't want to have needles poked into me. Really, as far as sexual function goes in the long term, they're the same. As far as bowel function goes, they're pretty close, and brachytherapy may have a couple % advantage. And urinary-wise, brachytherapy is just a little bit worse in terms of long-term kind of frequency and urgency a little bit. Although I think that gap has closed with the temporary implants that we do now and with modern planning. It's very nuanced. Each man is going to be a little different. Mm-hmm.
Can you make a comment about your targeting versus the biology of the cancers? Because it seems to me like you're trying to aim for the center of the tumor. The growth is going to be around the periphery.
Oh, so we treat the whole thing, yeah. So what happens is as the beams are intersecting, you're right there. Let's see, how can I answer that? So we'll always treat the whole thing. We'll never treat only the center. I have turned away patients where, for instance, I had previously treated an area and then they recurred immediately next to it and it's regrowing into the same area, and I just can't, because of normal tissue tolerance, I can't treat the area I did before again. And then you're right. There's no point in treating part of a tumor. You got to treat the whole thing. So we always will do that. But what you're also getting at is can we differentiate the dose? In other words, can I blast away at this part or this part of it a little bit more than, and change that? And yes. And so when I actually prescribe a dose and I say I'm giving 20 gray's the units we use, to the periphery of the tumor, when I do radiosurgery, I'm doing that, but I prescribe to what's called the 50% isodose line. That means 20 gray on the outside is actually half of what's happening internally. It's 40. So I'm really blasting away with gamma knife. But when I do prostate, I want it to be more homogeneous. Why? Because the urethra is running through the middle. So there I'll prescribe to the 97% isodose line to the periphery. The internal is only 3% hotter. So yes, I can also change that.
This is a more general question, so it may not actually make sense to you. By the way, great talk, but can you talk a little bit about the staging of surgery, radiotherapy, particularly about GU, GI cancers, and the issues around wound healing if you do radiotherapy before surgery?
Sure. So yeah, when we for all cancers, we talk about clinical staging and pathologic staging. So clinical staging is what everyone gets when they're initially diagnosed. You get pathologic staging if you're then treated by surgery, because you've removed it and you look at it under the microscope. And sometimes there's a discordance between those where you're upstaged or downstage, but 80–90% of the time your clinical stage ends up being your pathologic stage. For prostate cancer in particular, that matters, and other cancers in that when outcomes are published from surgical series, you have the advantage of having pathologic staging. Whereas when you look at outcomes from radiation series, you don't. You have the clinical stage. And so it's important when comparing surgery versus radiation that you're comparing apples to apples, not apples to oranges. So you compare patients who had the same clinical stage rather than pathologic stage versus clinical stage. For prostate, I mean, it's actually been proven now in a randomized trial 10 years down the road the survival is identical. There's no difference. And that's actually generally true for most things, but there are circumstances where surgery is better. I mean, all the time at tumor board, I will say, oh, this patient ought to have surgery, don't do radiation, or vice versa. The surgeon will say, this guy should have radiation, not surgery. That was part one of your question. I forget the second part.
Wound healing.
Oh, wound healing, yeah. So it all depends.
Then back, you know, if you end up having to do both.
Yeah. It sort of all depends on the cancer and the situation. And it's about dose and volume we're radiating. But like sarcomas, for instance, it's more common nowadays to do preoperative radiation, shrink it up, because you get a better chance of clearing margins all the way around, which is the single most important factor for long-term cure. Prostate, other cancers, we commonly will do radiation when PSAs recur after surgery, and patients do great. The chance of severe side effects is slim. The opposite is true for gynecologic cancers. Many studies have actually shown it's better if you're going to do surgery and you can predict they're going to end up needing radiation anyway, don't. Just do radiation and chemo, because it's actually less side effects in the long term than doing surgery to then follow it by radiation. So it depends on the particular situation. There's tons of research into that. Even like Dupuytren's, when I treat for benign conditions, that's a worry among hand surgeons, because none of them have ever heard of doing radiation for Dupuytren's, for the most part. But in fact, there's a couple thousand patients who've been followed, and there's no increased wound healing by doing low dose radiation, because it's pretty low dose to the hand. So it just depends. Either. So, yeah. Oh, how does it work? Yeah. So we do either. For patients who've had a bleed based on essentially it boils down to their life expectancy. If they're going to, the general risk of bleeding from an AVM is about 2 to 4% per year. If you've bled from it, that risk is even higher. And then depending on if it's deep and how big it is and other factors, that may be even higher than that. So we adjust that depending on how long the patient's probably going to live otherwise. And then for patients who've never had a bleed, you may be familiar with the Aruba trial, which is published. That's looked at surveillance versus intervention, embolization, surgery, radiation. And it didn't show a survival benefit at 3 years. But that's actually kind of a flawed, or I would say unfortunate that that was published at 3 years of outcomes, because if the bleed rate is only 2 to 4% per year, and you obliterate or get it, you take all your risk up front with embolization or surgery or radiation, and some people are going to have complications or bleed anyway. And over 3 years, you're not going to see a difference. But over 5 or 10 or 15 years, then you will. When we do use radiation for AVMs, essentially what happens is we blast away at it. That same concept of the periphery gets a pretty low dose, but internally it's a pretty high dose. And basically you get internal scar tissue within the vessel that slowly forms over about 2 to 3 years, and it just slowly collapses the vessel down to almost capillary size again. And so overall, about 70% of the time you'll have obliteration of the AVM. That's very much dependent on, it's sometimes as low as 20%, it's sometimes as high as 90%, but if you take all comers, it's about 70%. Oh, you have yes, that's a good question. So a good study from Japan with like 500 patients. They irradiated them, and then over 3 years, 70% or so ultimately were angiographically obliterated. During that interval, their risk of bleed was about 1 to 2%. So it's about half of what it otherwise would have been expected to be. So it reduces the risk of bleeding until it's obliterated, but it doesn't eliminate it. So I still counsel patients about avoiding elevated intracranial pressure and so on. Thank you. Oh, good. Thanks.
So much.